The American Society of Anesthesiologists' difficult airway guidelines recommend an awake fiber optic intubation as the gold standard technique in managing a patient whose intubation has been challenging by traditional techniques. The equipment required to perform a fiber optic intubation includes a fiber optic scope. Lubricate the scope prior to the procedure, taking care to keep the tip and camera lens clean. A monitor connected to the scope is helpful for improved visualization and for teaching purposes. Additional equipment includes a variety of cuffed endotracheal tubes, a tongue depressor, lidocaine ointment, 4% lidocaine, topical anesthetic spray, cotton pledgets, a nasal trumpet with 7/0 endotracheal tube connector, a flexible corrugated adapter, a number 10 Williams oral airway, lubricant, lidocaine with phenylephrine, and right-angle forceps. Maintain the patient in a sitting position at a 30 to 45 degree angle. Administer oxygen via nasal cannula. Keep the patient comfortable by providing appropriate sedation. Administer a dose of an anti-sialagogue, such as 0.3 milligrams per kilogram of glycopyrrolate, through the patient's IV. To prepare for the oral airway block, apply 1 milliliter of 5% lidocaine paste to both sides of a tongue depressor. You may choose to place a nasal trumpet during the procedure. Use the remaining viscous lidocaine solution to lubricate the distal tip of the airway. Attach the distal tip of the trumpet with a 7/0 endotracheal tube connector. Place the wooden depressor on the patient's tongue and ask him or her to suck on the stick. Every 1 to 2 minutes, as the patient tolerates, advance the tongue depressor into the mouth to anesthetize the tongue and posterior palate. When the patient can tolerate the tongue depressor at the back of the tongue, lidocaine spray can be applied to each palatine tonsil. Using an atomizer, spray local anesthetic on each tonsil to block the glossopharyngeal nerve. Ask the patient to take a deep breath with each spray. Administer 3 1-second sprays to each tonsillar pillar. Many practitioners perform an awake fiber optic intubation while the patient receives oxygen via nasal cannula. An alternative technique is to place a nasal airway during the procedure. The lidocaine phenylephrine mixture needs to be injected from a syringe into the nair used for the nasal trumpet. It is mandatory to lubricate, anesthetize, and shrink the blood vessels in the nose to prevent bleeding caused by trauma to the soft tissue during nasal airway insertion. Insert the trumpet into the patient's nair. Connect the corrugated adapter to the breathing circuit. Turn on the oxygen flow to 10 liters per minute to improve oxygenation. Remove the tongue depressor from the patient's mouth. Place 2 cotton pledgets soaked in 4% lidocaine into right-angle forceps. Keep the pledget within the right-angle tips and wrap the attached string around the handle of the forceps. This prevents the pledget from getting lost in the posterior pharynx. Place the cotton pledget into the patient's mouth. Direct the forceps toward the piriform fossa, the small recess located on either side of the larynx within the hypopharynx. Apply the cotton pledgets to the laryngeal mucosa in the piriform fossa. Hold the pledget in place for 90 to 120 seconds. Repeat this process on the contralateral side. Palpate the inferolateral aspect of the mandible to confirm the correct location of the pledgets. Insert a number 10 Williams intubating oral airway into the patient's mouth. Remove the endotracheal tube connector from the tube. thread the endotracheal tube over the fiber optic scope. Loosely tape the tube to the scope. Hold the fiber optic handle in your dominant hand and direct the flexible probe with the opposite hand. Insert the fiber optic scope and endotracheal tube into the oral airway with the bevel of the tube facing the patient's nose, such that the bevel faces the posterior airway during the intubation. Keep the fiber optic scope aligned with the midline of the patient's mouth. Advance the fiber optic scope watching the video monitor. As you emerge from the oral airway, you can see the tip of the nasal trumpet and epiglottis. Proceed carefully until the glottic opening is visualized. Identify the corniculate and cuneiform tubercles, aryepiglottic fold, false vocal cords, and true vocal cords. Cover the suction source. Spray 2 milliliters of 2% lidocaine via the bronchoscope through the vocal cords to block the recurrent laryngeal nerve. Wait approximately 30 seconds and advance the fiber optic scope and endotracheal tube through the vocal cords. If the endotracheal tube will not pass easily through the cords, the beveled tip may be caught on the right arytenoid cartilage. Withdraw the tube 4 centimeters and rotate it 90 degrees counterclockwise. Advance the tube again, attempting to gently pass the tube through the vocal cords. Gently advance the scope until the carina is visualized. Withdraw the fiber optic scope, leaving the endotracheal tube in place. Remove the Williams oral airway. Reattach the endotracheal connector to the tube, and attach the tube to the ventilator. With the airway secured, the patient may be induced at this time. Alternatively, the practitioner may choose to leave the patient awake while confirming tube placement. Here, the patient continues to breathe spontaneously, as evidenced by the end tidal carbon dioxide. She follows commands to take a deep breath and can move her toes when asked. While the patient remains awake, use the fiber optic scope to confirm the location of the tube in the trachea. Visualize the tip of the endotracheal tube in the trachea and readjust its position until it sits 2 centimeters above the carina. With the endotracheal tube in the correct location, inflate the cuff with a clean syringe. After the endotracheal tube is correctly placed, the airway is protected and it is safe to anesthetize the patient.